Thanks for having me, Terry. And it's really such an honor to be here. I work with a lot of ALS data, and as a statistician rather than a clinician, I really don't have a lot of opportunity to work with patients. And so it's just such an honor to meet you guys, and it's an inspiration. It's not an easy disease, and you guys have such vitality and energy. So it's an honor to work with you and try to move ourselves forward, try to find some solutions. So, the topic I wanted to engage you with this morning, hopefully you've had your coffee. We have a morning of statistics. Oh, sorry, I should say I have some interactions with industry. It's good to know where people commitments are. I feel very committed to the academic research, so I don't feel that these I don't feel they bias me, but it's hard to be perceptive when you're in the middle of it. So I do have some engagements. Almost all of these are through MGH, just supporting my salary. But so what are we doing this morning? There's a lot of data out there. There's a lot of information you're going to have exposure to as you read the literature, as you read the papers, as you talk with other patients and with caregivers and with your doctors. And so the broadest overview is, how do you sort out what might be how do you sort out truth from misleading data? How do we make a judgment about whether some claim of benefit from a treatment is real? And that's sort of the thrust of the whole talk, is how do you think about a set of results and make some judgment about what you should interpret from them? And there's two broad things that I want to draw our attention to. One is sort of, how does study design influence what is good study design, and then how does that assist us in making that judgment between what to believe and what might not be the case. And there's two pieces of that, whether the groups were comparable, whether the people who were being treated are a comparable group to those who are not being treated, whether the assessments of those folks are unbiased. And then, because I'm a statistician, I want to help you think a little about how stats folks think about a set of data, and that's going to focus around the question of chance. So here's my gratuitous puppy picture. I want you to be informed consumers, or at least have a cute puppy in your life. So this is sort of the bulk of the start of the talk. It's focused around a thought experiment, and it's sort of introduced as a way to help us all give one very concrete context for thinking about the various problems that the researchers, myself, and you, as whether you're researchers or whether you're now just receiving the data, can think about a set of data from an experiment and make some judgment about what we've learned from it. So the thought experiment is that you're feeling tired. You're newly fatigued. You've been feeling okay, and now you're not feeling so great. And a friend who you're out for a walk with says, "Oh, you tried this Chinese herbal medication, and I'm feeling so much better. You might want to try that too." And so you try it. You try it for a whole week, and at the end of the week, you are feeling substantially better. And so the question is, did that Chinese herbal treatment that your friend recommended to you, did it in fact help you? And I'm going to run through 6 different scenarios, 6 different situations, or sort of underlying truths that led to that, concordant with that combination of feeling tired, starting a Chinese herbal, and feeling better after the week. And so the first scenario, the first situation that could be true is that the Chinese herbal really did help you, and not only might help you, but might help others. So that's exactly that's the interpretation we're striving for. When we run a clinical trial, that's the goal that we're striving for. We want to discover treatments that are truly efficacious, that truly help people improve their health. But there are 5 more scenarios that we're going to run through where that wasn't actually the situation, but it still might have looked that way, where you felt better but the Chinese herbal wasn't the source of that benefit. And so we're going to try to think about how can we avoid being misled? How can we avoid misinterpreting our observations as evidence of benefit? So the first one, and you may have heard this term, is a placebo effect. So the scenario here is your friend recommended that you take this Chinese herbal, that it worked for them. You were hopeful that it would work for you. Maybe you slept better. There are all kinds of different situations. I guess I want to, sort of the central piece here is there are ways that our minds influence how we perceive and how our bodies function. Some of those are real effects. So although this is called a placebo effect, and they might seem like a disparaging term, there are real benefits from a therapeutic interaction. When you go to see Terry or you go to see Rick, and they say, I understand what you're feeling. I think we have something that's going to help you. That can have a real therapeutic effect because your mind has a control over your physiology. There's plenty of disease groups we've studied where we can actually measure that therapeutic effect of the empathy that you have from the care that you receive. That's real, but it's not changing necessarily the underlying disease course. It's not really intervening on the disease in the way that we might hope to, and it's hard to have that be a persistent effect. It's hard to replicate that benefit and have it persist over long term. So it's not what we're striving for, but I don't want to dismiss it as an irrelevant piece. So anyhow, so that's scenario one where we might be misled. We've taken the Chinese herbal, we hoped it would benefit us, and perhaps because we slept better or we're just feeling hopeful, we actually did feel a little less fatigued at the end of the week. The other scenario, or one other scenario, the next scenario where we might be misled is focusing on those times which you actually feel better. So this is under this heading of biased assessment. So you knew that you took the Chinese herbal, and you may have been more attentive to those times when you were feeling better. You had this whole hopefulness, and you thought, oh yeah, right now I guess I am feeling a little bit better. Whereas if you'd had access to a purely objective measure, it might be that your energy levels, your fatigue was not substantially improved. So this is an issue when both for patients and for investigators in a clinical trial. If the investigators know that they're treating one group of patients with an active treatment, and they know they're treating with another group with the standard of care with placebo, they may alter how they treat those patients because of that knowledge. They may unconsciously score people a little bit differently because they're optimistic. They may intervene in different ways because they're concerned that they know that the placebo might not be helping that patient, and so they might be more aggressive in trying to step in and provide other clinical care. So there's ways that knowledge of what you're exposed to can influence both behaviors and assessments, and that can lead to the observation of improvement when, on average and objectively, there might not have been an improvement. The fourth scenario where we can get misled is called confounding. One hypothetical situation would be that you were feeling tired because you had a cold that was coming on, and across that week, your cold cleared up. Your immune system kicked in, cleared out that virus, and your, by the end of the week, you no longer had that cold, and you no longer were feeling fatigued from it. The Chinese herbal might not have had any effect on the cold, but just the temporal alignment of those two events of starting the Chinese herbal when you were sick and that illness resolving over the week would lead to the observation that the Chinese herbal was associated with improvement. But there's something else going on. It's very hard in an observational setting for there not to be something that could function like that. there's all kinds of things happening to us all the time, and um, there's no easy way in an observational setting to know whether something might be going on for one patient, one individual, that's going to change over time for them, unrelated to what you've done to try to intervene. This infection that clears up at the same time, that's positive confounding, where there's something that's moving in parallel and you know, creates the appearance of benefit when it's not there. There's also potential for negative confounding. You know, it could have gone the other direction, where Chinese herbal was truly beneficial, but across the week you picked up a cold, and by the end of the week you didn't feel any better, and you didn't observe the benefit of the Chinese herbal because at the same time you had picked up that cold. So confounding can either create false associations or obscure and negate real associations. So it's a very difficult source of misleading information, because we don't know whether when we've observed something that's real, or we don't know when we've not observed something whether that was real. So anyhow, that's a central piece, and we'll say just a little bit more about that too. The fifth scenario is what's called regression to the mean. That fatigue, like many symptoms, is, you know, has some natural cycle. Sometimes you feel very energetic. You wake up in the morning and you feel great. Sometimes you wake up in the morning and think, oh my gosh, it's another day. How am I going to get through? And that can fluctuate from time to time. If you know, when did you take the Chinese herbal? You didn't take the Chinese herbal when you were feeling great. You only took the Chinese herbal when you're feeling tired. When you commented to your friend that, oh, you know, I'm really feeling kind of lousy this morning, and they say, oh, well, I've got something for you. So if you always intervene or start your observation at one extreme of some natural fluctuation, you're going to have the tendency to get, you know, for that symptom to change over time back towards the norm, back towards the mean, regression to the mean, in a way that has nothing necessarily to do with the intervention itself, but just the point in time that you started observing it. We see this in clinical trials, where I ran a study of acupuncture for high blood pressure, and we only enrolled patients who had high blood pressure. So you had to have a qualifying blood pressure in order to get into the study. But, you know, we're going to then oversample some people who just happen to be at a high point in their blood pressure cycles. You know, that on that day they were feeling, you know, they'd had a very salty meal at lunch, or they just run up the stairs. You know, we tried to control for these things, but there's still the opportunity that, because we set this threshold, that you could only get in the study if you had high enough blood pressure. Some people's blood pressure is going to naturally decline again, and we saw about a 5 millimeter mercury improvement in systolic. So anyhow, that's just one sort of example. The last situation that can obscure our discernment of what might really be happening, we call just chance. And it's really just that we don't know what's going on. It's not explainable in any way that we can interpret. Chance is always a possibility. There's so much complexity in the world, so much about the human biology we don't understand. It may not have been the Chinese herbal. It may not have been some confounding infection. It may not have been just regression of some natural oscillation. It may not have been bias in your perception. It's just something else, and we don't really know what that is. And we describe that as some unexplained chance phenomenon. That's always possible. So those are these 5 scenarios that are obstacles to our correct interpretation: a placebo effect, bias assessment, confounding, regression to the mean, and chance. And we're going to use study design to try to overcome the first 4 of those, try to set up a way of collecting data that reduces the likely influence of those first 4. And we're going to describe later how we use statistics to try to make some judgment about whether chance is a reasonable explanation, a plausible explanation or not. Oops. So sort of working forward in that, how would we increase our confidence? We have this one currently, you know, in my little thought experiment with you, we have this one bit of data. We were feeling tired. We took a Chinese herbal once. We felt better. That's sort of the least amount of information that we might have available to us when trying to make this judgment. The next way we might increase our confidence in that result is if you stopped taking the Chinese herbal and felt tired again, and then started taking it and felt less tired, and you could do that back and forth several times. That I'm sorry, I'm on to number two. The first way would be if your fatigue had been long-standing, if your fatigue had been with you for weeks, for months, and then only right at that point in time when you started taking the Chinese herbal was there a dramatic improvement. That would be that would increase our confidence. And if it was just sort of a one-off, oh, I'm feeling tired this morning, your friend gives you a Chinese herbal, and the next week you're better. So that long-standing history that changes at the point in time that you initiate the treatment, that would increase our confidence. And then, I'm sorry, I jumped ahead. The reversibility, if you could start and stop and influence your fatigue multiple times in both directions, that would certainly increase our confidence that it was the Chinese herbal that truly was the source of that improvement. The next step that might increase our confidence is if many, you know, you had a bunch of friends who had tried it, who all had felt the same level of fatigue and all felt better after taking the Chinese herbal. That generalizability, that common experience would improve the likelihood, would increase the likelihood that the Chinese herbal was the source of that improvement. These are then, you know, keep going further. So what if some friends took the Chinese herbal and some friends didn't take the Chinese herbal, and only those who decided to take it started feeling better? That would also further increase our confidence that it was the Chinese herbal itself that was having the benefit. And then getting into a real experimental design, if some patients were blinded, if everyone were blinded, rather, sorry, if everyone were blinded and the people who were taking it didn't know whether they're taking it or not, and those who were taking it didn't know whether they're taking it or not, and only those who truly were given the real Chinese herbal, if those are the people who got better, that's going to, you know, give us very strong confidence. If that was among a very large sample, then we would have as much confidence as we could hope for. So a randomized controlled blinded trial has the following benefits for us. It reduces the potential for biased assessment because everyone's blinded. Neither the participants nor the investigators have the opportunity for their inner perceptions to bleed through into their management or their scoring of patients' severity. Randomization prevents any confounding. So if you randomize a large group of people, it's equally likely that the folks who entered the study with a cold are going to be exposed to both conditions. It's equally likely that the people who are going to develop a cold over the course of their treatment are going to be in each of the two conditions. So randomization fulfills a really central role in avoiding this complication of confounding. And it's what fundamentally distinguishes a clinical trial from an observational study, where we can randomly assign participants to one treatment or another. We know because of that design that there's minimal opportunity, that we've minimized the opportunity for confounding of any of the unknown, unobservable features that may be temporally associated with the treatment that we've proposed. And then randomization also has the benefit, randomization and blinding have the benefit of minimizing placebo effects and giving us a comparison group which is comparable because, again, they've been randomized to it. And regression of the mean, again, both patients who are receiving active and the placebo treatment or standard of care treatment are going to have equal likelihood of experiencing regression of the mean. So the one feature that a randomized controlled blinded trial doesn't account for is chance. And so that's what we'll talk about now. So how do we decide if chance is a reasonable explanation? When we were just thinking about ourselves and taking the Chinese herbal ourselves and getting better, that wasn't going to be very convincing. If 2 people took a Chinese herbal and 2 people took a placebo, and only the people on the Chinese herbal got better, that certainly increases our confidence that maybe it's the Chinese herbal. But we're probably still not going to be convinced. FDA is not going to provide a label for that Chinese herbal to treat fatigue. If we had 20 people who took the Chinese herbal and 20 who took placebo, and only the people on the Chinese herbal got better, that's now becoming substantial amount of evidence that the Chinese herbal, something associated with the Chinese herbal, was unique and might be the basis for the improvement. So at some point, somewhere in the spectrum of volume of information, we're going to start to feel more confident. And statistics is there to help us give some numbers to this. So here's just sort of a graphic to try to explain, give a visual presentation of what we're thinking. So here's ourselves. We took the Chinese herbal. Before we took it, we were on this arbitrary fatigue scale. We were somewhere up around 15. And by the end, our fatigue had improved substantially. So my little zoom. This is comparing ourselves to one other person who didn't take the Chinese herbal and didn't get better. That if you looked at that graph, you'd say, okay, well, there's an association, but it's not very compelling. Here's the 2 people taking the Chinese herbal and 2 people taking placebo, and you start to see that there's a little more support. It's becoming less and less likely that you would see that by chance. And here's all 20 who taken the Chinese herbal in blue. They've all gotten better. 20 people taking placebo, none of them gotten better. That sort of magnitude of separation starts to become very compelling evidence that something associated with taking that Chinese herbal had some influence on their outcome. And here's statisticians love coins, so you'll have to bear with me, but imagine taking the Chinese herbal is like flipping a nickel, and taking the placebo is like flipping a penny. And if you get a heads, then that's a win. So what's the likelihood that if one person took the Chinese herbal and one person took placebo, and only the person taking the Chinese herbal got better, that's like flipping a nickel and getting a head once, and flipping a penny and getting a tail once. Each of those, if the coins are fair, happens 1/2 of the time. And so the combination of those 2 events only happens 1/4 of the time by chance. Flipping a nickel twice and getting 2 heads, and a penny twice and getting 2 tails, that happens only 1/16 of the time. When we get up to 20, flipping a nickel 20 times, and each time it comes up heads, and flipping a penny 20 times, and each time it comes up tails, that only happens an astronomically small percentage of the time by chance. And so we've clearly, whatever this is, 1 in 10 to the trillionth, that's a very low probability. It's implausible that we would have observed that sort of effect just by chance. So we've certainly crossed the line. This leads us now to a p-value. So you probably have heard of p-values, and you might have read in the literature, well, we are declaring this significant, p less than 0.05. So, but what does that mean? And it relates to this threshold at which we're saying there's enough evidence for there to be, for us to conclude that there might be some benefit. So p less than 0.05, there's a lot wrapped up in that. And so I'm going to try and unpack it a bit. It's related to hypothesis testing, and a particular form of hypothesis testing. So we evaluate chance through this hypothesis testing framework, and we posit a null hypothesis and an alternative hypothesis. So the null hypothesis is that there's no benefit, that there's no effect of the Chinese herbal. What we'd like to make some judgment about is the alternative, the beneficial effect. Was there some benefit from this Chinese herbal? And we're contrasting that with the null hypothesis of no benefit. So we want information about the beneficial effect, but we're going to take a backwards approach to it and ask, well, what if there was no effect of the Chinese herbal? So we've got two options. We can either accept the null hypothesis or we can reject the null hypothesis. If the results we see, assuming that the null hypothesis were true, would be observed with reasonable chance, then we might say it's reasonable to accept that the null hypothesis is a basis for explaining. If chance is a good explanation, you know, if we just had to flip one nickel and one penny, and you know, a quarter of the time that would come up in the direction we observed, that's a reasonable explanation for the results. When we flipped 20, you know, when 20 people got better and 20 people didn't get better, it's highly unlikely that that was just chance. And so this is the only sort of numerical piece here. We have a little number line 0 to 1, the probability of observing our result given that the null hypothesis were true. And if the probability is very low down in this region, then we're going to reject the null hypothesis. If the probability is somewhere up towards 100%, we're going to say, well, it's reasonable that we might accept that chance was an explanation. And the p-value, this thing that we call the p-value, is exactly this number. It's this, what's the probability of observing our result or something better if, in fact, there was no effect of our intervention. So p-value is probably of observed event or more extreme if the null hypothesis were true. So this is a form of proof by contradiction. You know, we're going to evaluate the thing we don't believe in, and if we reject that, then we'll accept our alternative. So if P implies not Q, then showing Q implies not P. And this is the best part of the whole talk, because I'm get to share this with you. Okay, you may want to turn up your volume. I hope this is loud enough for everyone. This is Jacques Cousteau. Where's my, here we
go. My name is Professor Guy Gadbois, medieval council authorities from Marseille. Do you have a ring? I do not know what a ring is. Zimmer. That is what I have been saying, you idiot. Please.
Okay, that's not the statistics yet. So the statistics is coming up right here. So keep a close eye.
I thought you said your dad did not bite. That was not my talk.
Okay, well, I don't get to see whether any of you guys are laughing, but I can't help myself from that. So I grew up with Pink Panther as one of my favorites, but so Clouseau asks, does your dog bite? The clerk says, no, my dog does not bite. Clouseau reaches down. The dog bites Clouseau. I thought you said your dog does not bite. That is not my dog. So did you see the statistic? Do you see the proof by contradiction? If that is my dog implies that it does not bite, then when the dog bites Clouseau, it implies that it's not my dog. So there you go. That's how statisticians think about evidence. So whenever you see a p-value now, hopefully you'll get at least a small smile on your face and like, right, dog. Why were we supposed to think about the dog biting? Oh, right. It's because this is completely backwards. We're trying to decide whether the dog shouldn't have bite. No. Anyhow, you'll come back to the slide and say, if that's my dog implies it doesn't bite, then when the dog bites, that's not my dog. If the null hypothesis is not plausible, then the alternative is plausible. Okay, so that's where we're trying to say, if the alternative or false implies that the null is true, and showing that the null is false implies that the alternative is true. Now we don't know truth and falsity, we just know probability. So If the alternative is not plausible implies that the null is plausible, then showing that the null is not plausible implies that the alternative is plausible. So just a little more on that. So a significant result, that an observation that, a calculation that p is less than 0.05 does not mean that the alternative is true. We're just talking about probabilities. We don't really know what the truth is out there. It means that our results were unlikely if the null hypothesis were true and our model that we used to calculate the p-value was correct. So we never have the benefit of knowing that something truly is effective, but we can say that there's very low probability that we would have seen such a benefit, such a consistent benefit among so many people just by chance. So we don't want to overinterpret significance, but it is one basis for making a judgment about the role of chance. Similarly, we don't want to go the other direction. If we have a result that's not, quote, not significant, p greater than 0.05, that doesn't mean that the null hypothesis is true. It means that whatever signal there was in the data was too weak for us to resolve it over the noise. There's a lot of variation from person to person, from any given observation to another. And if the benefit from that Chinese herbal was too small, we might not have observed it. Maybe all 20, we had the graphic there, all 20 people getting better from the Chinese herbal, but what if they got only a very little bit better, not much better than just the natural variation among the people who were on the placebo pill? It'd be much more difficult to resolve. We would probably not conclude that the benefit we saw on average was more than we'd expect by chance. But that doesn't mean that the Chinese herbal wasn't effective. It might be that it only was effective for a few people, or only effective minimally for many people. We just need more data to make a judgment. So we're next, the next set of things we're going to do this morning is looking at a paper. And so there's a few features to focus on in this paper or any others, or any other source of data that you're going to encounter. When you're trying to make some judgment about a benefit, are the people who received the treatment, are they comparable to the people who didn't receive the treatment? Was there some opportunity for confounding? Was there potential for placebo effects or regression to the mean? Was there blinding, and so avoidance of the potential for unconscious bias in assessments or treatment? Did all the participants get equivalent follow-up? If you only watch one group per day and another group for a week, you're going to observe different things about them, not because of the treatment, but because of how you observe them. And then lastly, was there the possibility that chance is a reasonable explanation? There's a few more things to say just to round out this conversation. One of them, I have another little aid here, multiple comparisons. So if we looked at a whole lot of features, if you took this Chinese herbal and for your fatigue, but you also, I don't have a good example there. Let me go straight to this heuristic here, this comic. So the question is, what if there were many things that we might have observed about people, and if we observed a benefit in one of them, should we believe that that's a real benefit or not? So this is a comic from XKCD, online comic people might know. Sorry, I need to find the pointer. So the first panel here, woman runs in, jelly beans cause acne. Oh my gosh, quick, scientists investigate. So the scientists come back and they say, we have found no link between jelly beans and acne, p greater than 0.05. So we now all know how to interpret that. So, well, that settles it. But she says, no, I hear it's only a certain color that causes acne. So they go back and they start testing all these different colors. So they report, though, no link between purple jelly beans and acne, no link between brown jelly beans and acne, no link between pink jelly beans and acne, no link between blue jelly beans and acne, teal jelly beans and acne, p greater than 0.05. No link between salmon, no link between red, no link between turquoise, no link between magenta, no link between yellow, gray, tan, cyan. We found a link between green jelly beans and acne, P less than 0.05. No link between mauve, no link between beige, no link between lilac, black, peach, orange, but they did find an association with green jelly beans. So what's the conclusion? Green jelly beans linked to acne, 95% confidence, only 5% chance of coincidence. Does that seem plausible? So that's the problem then of multiple comparisons. If you look at 20 different, so that if you count them up, that actually was 20 different colors that they tested. One of them reached this level of significance of chance finding 1 in 20 times, 0.05 being 1 in 20, and it would be misleading to interpret that as adequate support that in fact green jelly beans were associated with acne. We expect that any set of things, 20 things that we might test, if we use a threshold of 1 in 20 times, that we might expect to see one of those reach this level of significance. It's not just in this issue of multiple comparisons is not a problem only of how many endpoints you might look at, but how many different models you might have tested. So if you run your logistic regression with one set of covariates, and then you try a different set of covariates, or you have a mixed model and you have different covariance structures. Anyhow, there's all kinds of things that statisticians do in their modeling. And if they keep trying different models until they find one that has a p-value that looks good, that's not likely to be a good representation of the evidence. There's also appropriately a lot of interest in trying to understand subgroups. So I didn't give a graphic of it, but we mentioned it could be that the Chinese herbal, when we looked at 20 placebo, 20 Chinese herbal, only a couple people might have gotten better on the Chinese herbal. We would like to understand whether that was a subgroup who was specifically sensitive to the benefit from that Chinese herbal. And so we might try to understand whether there's distinct biology, distinct pharmacology that is applicable to one group, and a given treatment might help some people even if it doesn't help them all. And so you could look at all kinds of different subgroups in a given study and try to make sense of whether those are patients who might uniquely benefit. If you, again, say if you test 20 different subgroups, you're likely to find at least one that has a level of evidence of p less than 0.05. If you pre-specify that subgroup, then you can avoid that multiple comparisons. So there's sort of an exploratory phase where we might do some subgroup analyses, and then a future follow-up where you would try to evaluate that specific subgroup. And other sources, so conflicts of interest, my own as well as those of other presenters, other researchers or publishers, and differential loss to follow-up that's maybe more esoteric. So we're trying to get to the conclusions. So there are a few things to look at when you're evaluating a set of data. One is, was there use of good study design? Were there features of the way that the data were collected that tried to avoid the potential for confounding and for bias assessment and for differential effects of placebo or regression of the mean? And have we made some evaluation of the degree to which chance might be an explanation? And if you think through those pieces, you'll be well-informed, critical consumers. Oh, I'm very sorry. I forgot to tell you, there is a test here at the end. I need to get into the real display. Okay, how do we do this before? Okay, there's a test. Are you ready for your test? Here we go. So what does p less than 0.05 mean? And I don't know if I can really elicit that from everyone, but I'm sure you're all thinking in your head, it means excellent. No. No, we don't believe that. Excellent touch. No, because we just went through, there's other situations where you could have p less than 0.05 that's just from multiple comparisons. Okay, who knows? It's all Bass backwards to begin with. That might be the most common response. P less than 0.05 means there's less than a 5% chance of the observed result or better if the null hypothesis is true. So that's, if you checked your slides, you find that was right, but here's the, wait for it. It depends how many tests we've conducted. So there you go. Do you feel better informed? Hopefully, yes. Do you enjoy statistics? At least more than before. Hopefully, yes. There you go. Okay, that's the test. You passed the test. Thanks so much.
Thanks so much, Eric. We did have one
Oh, shoot.
question.
Hard to hear. I didn't even see.
Oh, thanks so much. Can you hear me now?
No. I'm sorry. I'm just reading the comment that it was saying hard to hear. So I fear that the whole talk was hard to hear.
No, it was just the Clouseau.
Oh, okay.
So we do have a question that you can see from Kevin. Kevin wants to know if there are any times when post hoc data is valid. Can post hoc data reveal a valid endpoint which, had it been selected, would have been statistically significant? And as an ambassador, how do we explain post hoc data that appears valid, but despite ALS being an unforgiving disease, the research community sticks with calling the trial invalid?
Yeah, that's a much. Let me start with the easier one. So two pieces to the first question. You know, how do we, what judgment might we make of a finding that wasn't pre-specified? So I think that's what the question. You know, post hoc, we've looked at the data. And we see some feature of the data, and now after the fact, looking at the data, we want to say, oh well, boy, this looks like really exciting observation. We hadn't thought about looking at it this way, but here, look at how much difference there is among this subgroup, for instance. If we can be disciplined and think, well, okay, how many different subgroups could we have possibly discerned? And when we look at this data, how many different possible ways could we have aligned it in our mind to try to ferret out and observe this? You know, our human perception is incredible. We've spent millions of years evolving it. So there are many different features that we might discern. But if there are, let's say, 1,000 of them, you know, 1,000 different ways that we could possibly have you know, recognized some pattern within the set of data, some subgroup or some endpoint or some combination of those two. And in one of those 1,000, we saw this beneficial effect. If that's a really, really strong effect, we have substantially greater confidence in it. If the p-value is less than 0.05, you know, with a 1 in 20 threshold, we're not likely to be convinced. But if the threshold is, you know, 1 in a million, that we would see a benefit so strong as what we observed, then even though we looked at 1,000 different things post hoc, you know, the 1 in a million chance would potentially override that problem, you know, that concern. So it's a gray zone. You know, we never, if we don't pre-specify, we don't really have a listing. We don't know how many things it is that we looked at, but we can make some, you know, some judgment of the multiplicity that might be involved in that analysis. So that's one approach, is to try to make it a post hoc adjustment for the implicit number of comparisons that we've made, and see whether that adjusted p-value, after we've acknowledged that we've made a lot of different post hoc comparisons, whether we still feel convinced. The other approach is to collect a little more data, to say, okay, that looks really exciting. Let's try to understand it more. Let's try to confirm that what we observe here really is a valid interpretation. That's always available to us, and I think I hear in the second question that maybe we, as a research community, we fall back on that confidence too often, that we're not willing to move forward with an observation unless we've spent another 5 years trying to investigate it. And I certainly hear the frustration and disappointment from the patient community that that's a timeline that doesn't really work. So I don't maybe I don't have a statistical answer to the second piece. I don't know, Terry or Rick, if you want to give some more context for how we, where do we draw this line of where we have enough evidence and where we need more evidence?
Yeah, so Eric, I'll just make a comment. So I feel like there's two types of subgroup analysis. The first is what's called a pre-specified subgroup analysis, where you do a study and you have some theories that maybe it won't work for everybody in the study, but maybe there's going to be a subset of people based on their biology that you plan to do a separate analysis on. I mean, let's say we had a marker of neuroinflammation and we weren't entirely sure that it worked, but we had a theory that it could identify people who had lots of neuroinflammation, and we were studying some new anti-inflammatory treatment, and we were just going to give it to all comers, but then we were going to plan to separately analyze those people that had an elevation in that marker. I mean, I think that's completely legit. But the other type of subgroup analysis, the one that's much more common, is when the study comes out negative, people cut the data up in every possible way they can think of. Let's see if it worked in tall people or short people, or people with ALS for this long or that long, or this rate of progression or that rate of progression. And I mean, there's nothing wrong with doing that. We hate to just completely throw out something that we spent years and millions of dollars on. But to me, those types of unplanned post hoc subgroup analyses are best as hypothesis generators. And really, when we look back over the history of ALS trials, more often than not, the follow-up on those kinds of subgroups doesn't lead us anywhere. So I would say most recently we had a drug called NP001, and there was a trial. Overall, the trial wasn't able to show a benefit, but they came up with this idea that maybe there was a subset of patients who had this marker, C-reactive protein, that if it was elevated, they were the ones that showed a benefit. So they did a second trial in those types of patients. Perfectly reasonable idea. Unfortunately, that trial was also negative. But now out of that trial, they have yet another subset, people within a certain age range and an elevated C-reactive protein. So, I mean, if they want to follow that up, that's great. But I just think that we have to be careful. Now, there are examples of companies that have done this and actually gotten a positive result that changed approval. So MT Pharma is an example. I mean, they did a trial of Radicava. It didn't work. It was published as a negative study, but they went back afterward and said, it looks like maybe people who are early in the course of the disease with a lot of function and a rapid progression might have benefited. Not a subgroup that you would immediately, at least back then, think would be a responder, that their biology would be different. But nonetheless, they did a second trial and it was positive. And the explanation they came up with was, well, maybe with the scales that we have, we need to have a lot of points to start with, and we need somebody who's changing rapidly to see an effect over 6 months. Yeah, that actually makes sense. And so I think it was not only the fact that they had one positive trial, but that explanation of why there was a difference in the two trials that got them an FDA approval. And so that's the way I think about it, is there's ones that have a really good solid rationale that you plan for ahead of time. And then there's ones that, afterward, after a negative study, you're just sort of fishing. Nothing wrong with it, but I think those types really have to be followed up in a separate trial.
I guess I would emphasize it again, thanks, Rick, that there's a whole spectrum of level of evidence. I tried to give that in a couple of slides, just your single person, two people, generalizing, all of these things increase our confidence. One thing that erodes our confidence is if we haven't pre-specified it, if we just sort of discover it after the fact, that degrades our confidence. That doesn't mean it's not real, but it means it's much harder to feel such real confidence in that result. And if we're going to start prescribing it, charging people hundreds of dollars, exposing people to potential risks, we need to decide whether that's enough evidence or whether we need more evidence. And thus far, we've usually have edged towards probably need more evidence to support that.